Well, I think this has been really a very informative discussion, but before we conclude, I'd like to get everyone's final thoughts on what we've been talking about today. John?
Well, I think I'll come back to something that we alluded to a little bit ago, and that is the issue in follicular lymphoma of, how do we define a cure, and should we be trying to cure patients, which is obviously something we'd like to have happen, but the philosophy is really this polar: do you use all these new drugs early, and do you focus even on low risk patients because those are the ones who you might be able to cure, or at least are presumably easier to cure, or do you continue this kind of stepwise approach and so on? And when do we kind of flip into the strategy of front loading things a little bit more? And are we there yet, or what will it take to be there? I think is a really important question for the field.
Pierluigi?
I think one of the important concepts in the last few years is the potential role of chemo-free regimen in the treatment of the setting of follicular lymphoma. And as I said before, John, probably also we can use some chemo agent like polatuzumab, but more intelligent, more specific for the patient with a very low profile of toxicity. And the future could be to move as soon as possible into the concept of chemo-free regimen for our patients. So, because at the end of the day, I think that right now, every time we say it's an incurable disease, but everybody in our hands, we have some patient in continuous complete response treated with conventional chemotherapy for more than 7, 8, 10 years. Potentially, we can say, so right now it's possible to cure with the conventional chemotherapy at least 20%, 25%. And the dream is to increase this percentage of patients with a new agent, in particular with the concept of chemo-free regimen.
Got it. Lori, your thoughts?
I think the patient selection and being able to identify patients remains the biggest issue in follicular lymphoma. The fact that BCL2 inhibition, venetoclax, or similar really isn't effective as a single agent in follicular lymphoma, to me, highlights how little we understand about the biology of the disease, the microenvironment, and everything contributing. So I think until we get good models or markers to help predict which patient should take all of these approaches in a very exciting treatment era where we have so many options, it's going to be hard to dramatically progress the field. So focusing on that, I think, is the highest yield thing we can do.
Yeah, the venetoclax
so
issue in follicular
Yeah.
lymphoma, I think, is really a amazing, not what I would have predicted.
Right.
So, John, what are your thoughts?
Well, I kind of agree with everything that's been said before, but I like John's approach of saying that in this disease, we've just been continually seeing small incremental improvements. We haven't had that dramatic change in outcome that we were looking for, I guess, since rituximab itself. And although we keep looking for it, what we should remember is, of course, incrementally, those small incremental changes have made a huge impact on our patients with follicular lymphoma. They are living longer. We finally changed that curve that Sandy Horning had shown for years of no change in the natural history of follicular lymphoma. We're improving it, we're changing it. And as always, of course, I think that we really want to make the changes. We've got to go back to understand the biology of this disease better than we do, and really, if we want to talk about targeted therapies, let's really identify the targets that matter, and let's, that's what it's going to take. You've got, however, a problem in that we're talking here about we haven't cured the disease, but we get very long remissions. Clinical trials in this disease take decades to produce the results and the outcomes. How in that setting do we completely change the algorithm we've been talking about today?
Yeah, it's definitely a difficulty, and along those lines, if there is a group of patients that have a near normal life expectancy, and finding ways of looking at the biology and not subjecting those patients perhaps to some of these therapies, but focusing on those poor risk groups if we can define them, and that's going to move the needle. Well, this has been great, and on behalf of our panel, we hope you found this peer exchange to be useful and informative.